From the time I was probably 10 years old, we used to dissect animals and insects and collect butterflies and so forth. And there were several of us in the Boy Scouts, and we always worked as a team. And I was always the surgeon, and somebody else was always the pathologist, and somebody else was. I did my first surgery when I was 16. We were on we called it the Mission Mountain Expedition. I was born and raised in Milwaukee, and we took a trip with the Scouts. We took a lot of trips with the Scouts, but we went out to the Mission Mountains in Montana, the highest concentration of grizzly bear in the Bob Marshall Wilderness area. And we took a pack trip into the mountains with horses and mules and so forth. But I had seen our general surgeon, family surgeon, and a police surgeon. My father was a police officer. And I had equipped myself with needle holders, needle drivers, suture material, numbing sprays, antiseptics, bandages, and so forth, so that I would be prepared for any emergency. Well, one of my scout colleagues and I were climbing a glacier, just the two of us, when the rest of the camp was down at camp, and he slipped and slid down the glacier and tore his head open, and right down to the skull. And so we evacuated him and took him by raft across the lake, and I cleaned up his wounds and sewed them up. So that was my first opportunity to practice surgery. I was the original doctor here at Strax. This goes back about 6 years now, and then, of course, we've added a number of doctors since that time. I went to Harvard as an undergraduate, and then I got a fellowship to go to England, a Frank Knox Memorial Fellowship, and I went to the London Hospital Medical College and Oxford University Medical School and studied there, and then came back here to Harvard Medical School and took my MD from Harvard Medical School. I trained in surgery and in plastic surgery at the University of Michigan in Ann Arbor, and then I came down here and got out of the cold. I went from the general surgery residency into plastic surgery. It was a combined residency of general surgery and plastic surgery. And part of it is just a maturing process. Of course, I was a little overage in grade in the sense that I did other things before I went into residency. I was a chemist with the FDA for 5 years, and became a pharmaceutical specialist there, and then did my medical school and residency. So, but for a lot of people, it's a maturing process. You can enter plastic surgery either through ENT, or nose and throat, or orthopedics, or general surgery. And I chose general surgery. It's a matter of decision making and dealing with life and death issues and some of the more complex issues. Plastic surgery is a specialty that deals with all parts of the body. It's not specific to one part of the body. It's a conceptual type of problem solving. And in that sense, general surgery is a good preparation, because general surgery also deals with all parts of the body. So it's kind of a natural transition from dealing with general surgery and dealing with functional things about all parts of the body to plastic surgery dealing with aesthetic parts of the body. You know, cancer surgery is removal of the cancer first of all, but then it's also picking up the pieces and reconstructing it afterwards. So again, for plastic surgeons, it's all on a continuum, whether it's cancer removal or the reconstruction simultaneously, or the reconstructive later on. So I did a lot of skin cancer. At one point in my career, I was doing 3 days a week just doing nothing but skin cancers and breast cancers, and reconstruction, immediate reconstruction of that. And then I also did hand surgery for a while as well. But you know, from a technical point of view, plastic surgeons are really a surgeon's surgeon. In other words, well, we not only want to do the functional thing, but we want to make it look as good as possible and as aesthetic as possible. But it's really all on a continuum. There's no strict difference between extirpation and removal of cancers and trying to make the best result aesthetically afterward. I was in private practice for years before I joined Jeff, who owns Strax. I was with him at his previous venue here many years ago, so we've been together almost 15 years. This paradigm is unique. Really, it's very lonely in private practice when you're all by yourself and you have no backup and no support, and you make all the decisions and bear all the responsibilities. And it's getting increasingly more difficult to do that in the modern age as HMOs take over and everything gets devalued. So this model is fantastic for us for several reasons. First of all, for us as surgeons, it's a turnkey situation. We just come to work, we see the patients before surgery, we operate on them, and we see them after surgery. We don't have to worry about overhead hiring and firing, policy matters, legal matters, and so forth. It's pure surgery for us, which is any surgeon's dream. That's number one. Number two, the collegiality that we have is unbelievable. Nowhere does anybody have this many colleagues that they can ask questions of and learn from. I learn something from my colleagues every day, and there are no stupid questions. We can ask each other anything and share our results. So we learn things every day. Absolutely, or just planning for the surgery beforehand, or looking at your results afterwards and seeing how could I have done this better. So it's constantly trying to improve the quality of our work. It's something as simple as drain placement. For a tummy tuck, for example, most people use some drains for about a week or so just to catch any fluid that accumulates under the flap. And people have put the placement of the drains in various different places, either in the pubic area or in the groin and so forth. And Dr. Arago, who is our medical director, said, why don't you just lead them up the incision itself? And I've been doing that since that time, and of course people have a lot less discomfort from the drain side now. They used to complain bitterly about that, and they don't have any discomfort there now. And it saves them a couple of little scars too. So something as simple as that. Plus, some of us have more experience in one thing than another. Some of us have done more noses, some of us have done more breast, and so forth. And there's always something that you can pick up. Well, technically we all do everything, but I mean that's not strictly true. There are certain things that some of us like to do more than others. I do a lot of the mommy makeovers, if you will. After pregnancy takes its toll on the breast and on the abdomen and body in general, either with stretch marks, sagging, loss of volume, looseness, and so forth. So I do a lot of breast surgery, either in the form of augmentation or restoration of volume, breast lifts, combinations of lifts and augmentations, or breast reductions and lifts, and also abdominal surgery, either tightening up the abdomen and the underlying muscles after multiple pregnancies, or picking up the pieces, as it were, after lap band surgery when the patients lose massive amounts of weight. For years we did the post-lap band or post-gastric bypass surgery to pick up the skin that had fallen, to reduce the breast, to lift the breast, to tighten the tummy. And then we decided to do the lap band surgery as well, so that we could follow the patient from day one, and after they lost the weight, then we could also provide the services for them to make them look the best afterwards. So it's a beginning to end type of one-stop shopping, if you will. I do 10 or 15 of these a week with a combination of breast, tummy, and lipo, and it's very gratifying. It's instant, it's dramatic, and the people are generally very happy. I have 34,000 patients at this point. I do an average 2.4 procedures per patient, so you can do the numbers there. The more things you do, the more elegant the surgery becomes, meaning the more efficient, both time efficient and motion efficient, and that's what we strive for, elegance in surgery. There's not any two that are the same. Once you get into the surgery, you realize that each one has to be individualized. This is why everybody does not come up with the same nose, for example. These are not cookie-cutter noses, these are not cookie-cutter breasts, because each one is its own specific challenge. And all paired organs, like ears, breasts, and so forth, are asymmetrical to some degree or to a great degree, and that's an additional challenge. Never, that wouldn't work. The patient sees the doctor right from the get-go, right when the patient comes in, and the doctor decides what, if anything, is relevant for the patient, and then the patient gets the educational materials and the background and the pros and cons, risk-benefit ratio, and so forth, and then the doctor and the patient decide together what the patient's going to have. And the management is here to market the practice, to market the doctors, to bring the patients in, basically, So they do their part, and they run the business part of it. Most of us have been terrible businessmen. I'm a perfect example. You know, we ran our private practices, and we took good care of our employees and gave them raises every year and so forth, and took them out to dinner for their Christmas party, but we didn't look at the bottom line, and we didn't make it very efficient. We were extremely inefficient. We had no interest, at least I had no interest and no talent for business, which is why I went into medicine, and then I went into private practice, which is a small business. So we are so happy to give up all those headaches to these geniuses here and just do our thing. Always. Jeff Davis, who is head of this organization and who's really the brain power behind this, is a very brilliant person on all aspects. He knows more about plastic surgery than most plastic surgeons, I have to tell you. He's been doing this for so many years. I have to tell you that once in a while, when I'm stumped on something, he will come up with a surgical solution or a suggestion, and I'll say, why didn't I think of that? So that's what we're talking about here. This is not separation of businessmen who know nothing about plastic surgery. These are businessmen who knew more about plastic surgery than any other businessmen. This model, this paradigm is unique in the world, really, and this is the largest practice in the world. Group model is different from other groups. First of all, it's larger, and we have more degrees of expertise in different areas of expertise, number one. Number two, the closest thing you might think would be an academic setting where a number of plastic surgeons are in the department or section of plastic surgery. But that is a very different paradigm. It's really kind of cutthroat. It's extremely competitive, and the people are competing with each other for who can bill the most, and it's kind of a backstabbing situation. There's some mutual respect, I'm sure, but the pressure is such that it's not really collegial in many situations. We are freed from that. We are not competing with each other. Each of us has enough business that we are focusing on our own patients and our own approaches to problem solving. We're not quibbling with each other. We're focusing on the patient, not on each other, and looking over each other's shoulders. So it's to me, it's the ideal situation. We have economies of scale, exactly, so that we can have multiple lasers, we can have the latest equipment, we can have the latest training of anything. We can bring people, for example, Jeff brought one of the world experts in vaginal rejuvenation from California here, and he taught a course to 5 of us here about all different aspects of vaginal rejuvenation, vaginal tightening, labia reduction, bladder suspension for incontinence, and so forth. This was an intensive course here, and he's willing to bring us whatever kind of training or special equipment that we need to be state-of-the-art in delivering our services to our patients. We're always looking for the new technology. LipoX is one of the latest things, and it's a radiofrequency treatment for cellulite and fat reduction. It even reduces visceral fat. That's the fat inside the abdomen that traditional liposuction cannot access. But other new techniques, not necessarily intensive, for example, the liquid facelift or stem cell facelift. That's something that Jeff will often see the new trends in plastic surgery coming before we will, and he will encourage us to try these new techniques. For example, harvesting fat cells with liposuction and spinning them down and taking the stem cell fraction. Stem cells, as you know, are the pluripotential cells that can develop into whatever type of cell they're placed within. So you can take these stem cells and put them to facial injections along the creases here, or to fill out cheekbones or other bony features, and they serve as transplanted living cells, as opposed to using artificial fillers which only have a finite half-life. And the same thing goes with buttock enhancement, and it's really a type of recycling where you take fat from areas where you don't want it and place it in the areas where you do want it, as opposed to having the risks of buttock implants, for example. You can use your own tissue. So these are all cutting-edge stem cell type of things that are really on the crest of the wave, if you will.